One thing you were going to do is to intentionally spend the rest of your day thinking about what biases you may or may not have. And the truth is, almost inevitably, you've probably let a bias seep into your practice. And almost inevitably, it'll probably happen again in the future. And that's okay as long as you're willing to reflect on it and acknowledge it and grow.
All right, welcome to Hands On, Hands Off. Today we are diving into a topic that's often overlooked, but deeply impactful, and that is the role of gender in OMPT practice. I'm your host today, Moyo Tillery, and joining me is Dr. Sarah Shaver, whose work and insights are helping us rethink how gender dynamics shape patient-provider interactions in manual therapy. Dr. Shaver, welcome to the show.
Thank you. I'm excited to be here and to talk about gender and physical therapy.
Outstanding. It's great to see you. So let's start with a little background. Can you just briefly introduce yourself and your journey into orthopedic manual physical therapy?
So my name is Sarah Shaver. I use she, her pronouns. And I've been practicing for about 9 years now. I did my DPT at Husson University in Maine. I went on to do an orthopedic residency and become OCS certified. I did that out in Oregon. And then I gleefully moved back to the East Coast to Boston University, where I did my fellowship in orthopedic manual physical therapy. And I am currently at the tail end of my SCD program at Bellin College. But in the meantime, I am working full-time treating in the clinic in Providence in an outpatient orthopedic setting, working with a lot of young athletes, predominantly female or of the LGBTQIA plus community. But this topic of gender in practice is one that is near and dear to my heart, and I feel pretty passionate about its involvement and consideration in the role of healthcare in general, but even more specifically to physical therapy and OMP.
Yeah, I mean, I think you've queued us up perfectly with your background and your current work environment to dive right into this topic. So let's do it. What inspired your interest in exploring gender dynamics and then gender dynamics specific to OMPT? And perhaps before we even go deeper in our discussion, can we just level set for the listeners? Can you help us define gender in this context and perhaps why it's important to distinguish gender from sex when discussing clinical care?
Yes. I think it is really important first to differentiate between gender and sex. For the majority of this podcast, when we refer to females and males and men and women, we're going to be referring to the cis female and the cis male, and that is those assigned female at birth and those assigned male at birth, right? That is their sex. We're going to speak in this way largely because of how research has been conducted up until this point. Research today is still grossly and overwhelmingly lacking for the transgender, gender fluid, and non-binary community. I fully recognize and validate that community. I'm a member of the LGBTQIA community myself, but for the purpose of this podcast, because of how research has been conducted, we'll be using male and female to talk about the cis male and the cis female. So the sex assigned at birth by the provider.
That's awesome. Thank you so much for kind of grounding us there. I know that when you and I chatted before, we talked about some of the things that, maybe catapulted you into this line of research and work and practice. Some of them involving existing discrepancies, gender-related discrepancy in medicine and healthcare, but in PT specifically. And maybe some of your personal experiences, meaning you've observed some powerful anecdotes in your clinical work, particularly around maybe female providers feeling somewhat misunderstood or invalidated by their patients. And again, that patient-provider relationship. Leaning into your presentation at AOMPT, you reviewed a retrospective analysis with a huge number of cases, over 3 million. So can you tell us a little bit about maybe what you took from that? What did the data reveal about patient-provider gender discordance? And how does it compare to maybe what we see in broader healthcare literature? Can you just kind of take us into your world there?
Totally. So there were so many things that contributed to me heading down this road of interest and passion. And the first is that overwhelmingly, especially when entering my fellowship, a huge, overwhelming majority of my direct mentors were male. I really actually had to think deep into this to realize I had one mentor early on in my residency that was female, but overwhelmingly in the world of OMPT, my official mentors were male. I didn't have a lot of female representation from the mentor side of things,
Mm,
and it feels kind of similar when you walk into the AOMPT conference.
mm,
Sure, there are females walking around and they're there, but overwhelmingly we see a male presence, and we often see that even reflected on the stage in our presenters. So I think that that is improving with time. So that was the first thing, just feeling like even though I'm technically or theoretically in a female dominated field, then when we look at OMPT, we see a much more male dominated specialty. But even more so than that, even more meaningful to me is that whether it's a result of internalized bias, internalized
mm,
sexism, or overt bias, I'm not sure. It's probably a combination of both, but
mm,
overwhelmingly, I have personally watched so many patients. I have personally experienced, I have seen and felt the collective experience of the female of walking out of a healthcare appointment and watching that patient feel invalidated,
mm,
misunderstood, belittled, gaslit. Oh, maybe it isn't that bad. Um, isn't as bad as I thought it was. I wasn't taken seriously. My tests were negative. I was dismissed. I'm not sure
mm,
I got to say everything I wanted to say. I'm not sure they understood what I was saying. I just overwhelmingly was watching females feel invalidated and misunderstood when they
mm,
left a patient appointment. And we see this reflected quite frequently when females intentionally go out of their way to request another female provider. They're seeking someone that they think has the capacity to understand their perspective a little bit
mm,
more and who perhaps will listen to their perspective a
mm,
little bit more. And
mm,
listen, I fully believe that physical therapists are in this field with good intention, but this
mm,
collective experience is so broad that it's impossible to ignore. I mean, when we look at the ED, we see that men's pain is taken more seriously. They're
mm,
triaged more quickly than the female. We see that female patients are interrupted more frequently than the male provider. We have all this data to say that somehow, for some reason, females aren't quite receiving the same treatment or response when they're seeing their healthcare provider. And we can maybe perhaps extrapolate that to physical therapy, and we'll talk about that later. And then, really, what was the straw that broke the camel's back, if you will, is the study that you alluded to, which was by Wallace et al. And it was 1.3 million patients. It was a retrospective analysis looking at patient outcomes between surgeon and patient based on sex concordance or disconcordance. So whether or not the surgeon and the patient were of same or differing sex. And what was found, again, a retrospective analysis of over 1.3 million patients, is that when the surgeon was male and the patient was female, the patient within 30 days of surgery was at a statistically significantly increased risk for death, worse
mm,
overall postoperative outcomes, and readmission to hospital.
mm,
And that was the first peer-reviewed paper that I had read that truly just validated and almost slapped me in the face of this is happening. It is undeniable and it is real. And that kind of cascaded my interest and my involvement, I think, in this area of physical therapy and OMPT.
Yeah, that's scary. That's really scary. And anyone listening, you know at least one cisgendered female, right? You know at least one. And so if you're feeling separated or not connecting to this topic, you know at least one person, right? Who could be the person who experiences these negative outcomes because of a lack of conversation around this topic. So this is serious and this is very scary, and everybody has to be thinking about this. So thankful to have clinicians and leaders and um, innovators like yourself in this space, to bring us all to a level of practice that we should be at the level, obviously, of a fellow of manual therapy, but any clinician, even at entry level. So this is a crucial conversation. And you said something, Dr. Shaver, about kind of what led to this. The things you were hearing female patients say, and the female experience. Um, and at the foundation of that is the seeking concordance and seeking understanding. And I think that part of it, just to contextualize it again for the listeners, if you're feeling separate from this topic, any human being, right, regardless of sex and gender, race, and other identity differences, most people just seek concordance and understanding. That's just human nature, right? So just trying to, frame this work contextually in different ways. Everyone has to connect to this topic because it is crucial, right? And we don't need our patients to suffer and outcomes, like you mentioned, be perpetuated because of a lack of knowledge, awareness, or tools to kind of right the ship. I know that in your work as well, Dr. Shaver, um, you have specific clinical examples, to further help us connect to this data and this topic and this work. You and I talked a little bit about, maybe more common trends that we've heard of as physical therapists, like, ACL injury tears, female versus male. I think most of us know it's maybe more common for some reasons that we're kind of taught in a narrowed focus way. Q angles increased, right? But there's more. Let's talk about that. Can you give us some clinical examples that you've seen in your practice or that you've read about in your research that helps us parse this out a little bit further?
Totally. So there's kind of two parts there, and I'll start with the more broader question here, and then I'll dive into the little bit more PT and ACL side of things. So I would like to zoom out because I don't know that we can analyze where we currently are and figure out how to go forward without looking left and right and without looking backward. And by that, I mean, I want to talk about a couple examples where there's clear differences in sex-based outcomes in in healthcare. And it goes all the way back to 1993 because it wasn't until 1993 that women and minorities were required to be included in medical research. So we have this huge body of data that was done on male patients, that researchers and healthcare have just chose to assume perfectly extrapolates to the cisgendered female patient. And the truth is that it doesn't. And that's starting to become more and more clear. And unfortunately, we're seeing it come out in our outcomes. We can talk about the world of pharmacology, where women are nearly twofold greater risk of experiencing an adverse drug reaction across all drug classes, and are significantly more likely to be hospitalized as a result of these adverse drug reactions. We can talk about females in the emergency department, where a female is more likely to be wrongfully discharged from the ED with symptoms of unstable angina or myocardial infarction. That risk increases if the patient is non-white. We can talk about how a female presenting to the ED with a myocardial infarction is 2 to 3 times more likely to survive when being treated by a female provider. We can get away from the ED and we can talk about non-alcoholic septohepatitis, or NASH, which is experienced 50% more likely by females. However, men, despite controlling for all sorts of variables, are 11.9 more likely to receive a liver transplant. And women are more likely to die while waiting on the wait list for their liver transplant. They're more likely to be removed from the wait list altogether due to deterioration from condition. And they're more likely to just remain on the wait list indefinitely and unfortunately experience death. We can zoom out even farther. We can look farther left or farther right. We can look at a retrospective analysis by Doria Rose, looked at over 55,000 individuals and looked at the performance of sigmoidoscopies, right, and whether they were performed adequately or inadequately. And we see females significantly more likely to have a procedure that was performed that was deemed inadequate. And of those that had an inadequate procedure, they were 3 times more likely to go on to develop colorectal cancer.
Wow.
And you mentioned earlier, right, this is scary. And this feels terrifying to me as a cis woman. has health needs just like any other human. And I know in physical therapy, we're unlikely to be detecting on the regular colorectal cancer or heart attacks, right? And when I give this information to people, what is most commonly said to me by other therapists is, but physical therapy is different, right? We see our patients often 2 to 3 times a week. We see them for extended time. We form relationships in ways that other healthcare professionals don't. And listen, I hear you, but it is really difficult for me to believe that somehow we see these discrepancies in the rest of healthcare and somehow we as physical therapists are immune. It's really difficult for me to believe that somehow, given our current society, that these biases haven't permeated or affected physical therapy. And it's really difficult for me to hear you dismiss it so easily. So I think that brings us to a couple more PT specific examples. And the ACL is a classic one. It's commonly talked about how women are more likely to tear their ACL. They have wider childbearing hips. They have estrogen that makes their ligaments more lax. They have a greater Q angle, right? This is, I would say, probably commonly known and accepted language. However, when we look at that a little bit more closely, there's several variables that really should make us question that women are inherently more likely to tear their ACL. And the first is that we've watched over time the rate of male ACL tears decline. And we've seen the rate of female ACL tears either incline or stay the same, kind of depending on what you're referencing. So why do we have this graph that doesn't match? Especially when we have known and cited and researched ACL tear prevention protocols that have been designed for females, like the PEP program that the IOC, the International Olympic Committee, put out. We have these known programs that can decrease ACL tears by the rate of 60 to 80%, depending on the literature that you're looking at, and they're not being used. And again, my question is why? Is that ignorance? Is that overt sexism? Is it subconscious bias? But inherently, female ACL tears don't have to be at the rate that we are. And truly, we could even back up even farther, and we could look at studies of dancers that started when they were young. And the unique thing about these young dancers is that men and women often start dancing at the same age, and they train for years. And what we see in dancers is that there's very little difference between males and females, between their jumping mechanics, their landing mechanics, between their quad to hamstring ratio, and their ACL tear rates are about the same. You contrast that to something like soccer, where females are largely starting playing in their post-pubescent years. Males are starting to play in their pre-pubescent years. And we zoom out even farther and we see difference in strength training and kind of cultural upbringing based off of gender, right? My brother was asked to stack wood and carry the groceries in. I was asked to dust to sweep the ground, right? So even from a really super young age, we are strength training in a really gender segregated way, our males and our females differently. And then we're starting our sports at different times based off of females go through puberty 1 to 2-ish years before males, right? So males are strength training and doing their sport at the peak of their puberty, at the peak of the time where their muscle building and bone density mass is most influential. Females are starting after their puberty. And then we're socializing and training them differently and not initiating and providing them with the same resources and knowledge to strength train and work on these mechanics, right? So I would really like to challenge the idea that women are just inherently more likely to tear their ACLs. And maybe this comes down to societal expectations, how we are gendering tasks that we give our children, and even the information that we're giving them in sports and in physical therapy. I feel really frustrated. It happens all the time. Females come into the clinic and they're like, ugh, it's just like women are more likely to tear their ACL. I'm the 4th person on the soccer team this year that's torn their ACL. Like, it's just going to happen to the other side. It's just more likely in women. And there's this inherent sense of I'm weaker, I'm frailer, I've been defeated, probably going to tear the other one next year because that's what happened to women in soccer. I would really like to challenge that notion.
Yeah, it's You're challenging it right now in real time. It's happening. And, it starts with increased awareness. I sincerely appreciate your zooming. You're zooming out and taking us back to, 93, where the yardstick is off. If we're measuring something against something that is not accurate, everything from there is going to be inaccurate. And that's essentially, it sounds like that's what we're seeing, and that is really powerful, to kind of back it up and say that. And I've never thought about what you just said, which is we're training kids, right, to we I've never thought about the biomechanical implication of boys do this and girls do that, and gendering and roles and things like that. I mean, that is really powerful. Maybe others have, but I find that really insightful, within the context of this conversation, but of course, after that, beyond that. And, continuing to zoom out, you said something that I find also really powerful, which is it's an excuse. We as physical therapists are part of the healthcare system. And so whenever, and I think in the company of fellows in this community of practice, where I think we tend to think outside the box by default, which is sometimes why we pursue fellowship training, is whenever I hear something is inherent or like you're predisposed to something, especially when it comes with, um, the context of something really narrow, like gender or height or age or race or upbringing, or it's a red flag for me. So I appreciate that you're pushing back and challenging this, well, she's going to be more lax because she's a dancer, or she's going to be more flexible because she's a dancer. Maybe not. Maybe there's more. And what I'm hearing you say is that there is more. But the research to support that is lacking, at least specific to physical therapy. I have so many things, that I want to ask you about and chat with you about, but for the sake of time, can you bring us into, maybe where you are now, some of your, parallel collaborations, and maybe others that you've networked with and talked to who have worked in or around this space? What are those conversations like? What are you finding, whether it's in, certain groups of athletes or certain ages? Can you just talk to us a little bit about the research side and the scholarship side of what's happening, what's developing, maybe where you see things going as far as your specific work in this area?
Yeah, I mean, the scholarship in this area and the progression in this area is in a really, really fun time.
Mm,
One of my favorite places to network and discuss with other clinicians and providers, interdisciplinary, is the Female Athlete Conference. I'm going to give a little plug here. The Female Athlete Conference happens in Boston, Massachusetts, every other year, and it's an interdisciplinary conference full of physicians, orthopedics, physical therapists, nutritionists that are coming together to overall discuss physiology, pathology, and the treatment
mm,
of truly the female patient, but a little bit more specifically the female athlete,
mm,
and where I get to hear and talk to a lot of really cool researchers and hear some really novel research in the area. It was at this conference a couple years ago that my perception of very similar kind of concept to the ACL, my perception of concussions was challenged. I think really similarly to ACLs, providers often think about concussion and think, females have worse outcomes when it comes to
mm,
concussion. And I'm sure there's data that says that. But Christina Masters presented at the Female Athlete Conference, and specializes in concussion and works for the NFL and the National Women's Soccer League. But she put out a paper in 2021
mm,
looking at over 1,000 concussions from 30 different institutes, and really challenged the notion that females have a worse prognosis, because she found that within these D1 schools, when time to concussion to referral and first seeing the provider was the same, the prognosis between the sexes was the same.
mm,
She then went on to look at the same thing with the pediatric population and found the same outcome. This
mm,
is just another topic where I constantly hear presented and talked about how women have worse outcomes. I mean, it's been drilled into my head for a really long period of time, to really be questioned, and not supported by this research that Christina Masters is doing. It's just another area where we're letting preconceived beliefs and notions have a strong influence on our practice because we haven't taken the time as a society or healthcare to really look at this sex specific data. So Christina Masters did that work on concussions, and I'm sure she's continuing to research that. But also in this area, I mean, you can find references through the Australian Sport Institute, FASTR, FASTR, through Stanford, where there's constantly updated research about female physiology and pathology. And it's one of the places I go to kind of look for some new female specific research or in an area that I'm trying to learn more about. Yeah.
I appreciate, thank you for sprinkling some of those resources for us, for all of us. Appraising the evidence, I think, is something that we all, as in this community of practice, can really appreciate, and bridging the gaps in where we are as individual practitioners relative to some of the topics that we talk about, on this podcast, but obviously in clinical practice. I think you and I had another discussion where you provided some insight and really enlightened me on something that I think clinically I sort of witnessed and just uncomfortably brushed away as well, which is the use of manual therapy in chronic pain, and the impact of this being more negative towards women versus men, or female versus male. Do you mind just retelling that story from your perspective, and just any other nuggets that you have around the topic of the maybe inconsistent use of, or inappropriate use or disuse of manual therapy to address chronic pain, which has that influence on women?
Yeah. So a couple things come to mind. Women, anything can be disproven, but women often have more chronic pain than males. We see higher rates of things like cervicogenic headache, autoimmune diseases, right? So I think if I was to ask you to close your eyes and picture the chronic pain patient, I don't love that language, but picture a patient you've had with chronic pain. Most providers probably picture a female. And a really recurrent motif I've seen in the clinic, kind of one of two things, but more commonly are providers being like, this is a chronic pain patient. This is not someone we do manual therapy for. We need to do X, Y, and Z to address their pain, but we shouldn't do manual therapy for a chronic pain patient. And first, I really want to challenge the notion that any one diagnosis, no one should have something. Similarly to every one of your patients shouldn't have one thing, right? We need to be individualizing our care. But this concept of, hands off for chronic pain patients is disproportionately impacting female patients. It starts off with a tone of, I'm inherently making a judgment and deciding you don't get this treatment. It's belittling. And doesn't allow for a thorough assessment because you've already made a decision based on a diagnosis on what treatment this patient is or isn't getting without considering their history, the other healthcare that they've received, other personal, socioeconomic, racial things that might be going on that we might need to consider with this patient. You've pre-decided based on a diagnosis what is going on. And what you need to do and not do about it. Again, we see this with autoimmune conditions. We see this with chronic pain, the cervicogenic headache, where we've pre-decided a treatment route based off of maybe an area that I think most therapists or a lot of therapists prefer not to treat even, and have decided they're not going to receive manual therapy. Just like not everybody needs manual therapy. We don't get to say, hey, this diagnosis doesn't get it at all. That's really disproportionately impacting female patients. And that's brings me kind of to the thought process of really similarly therapists saying, I'm not biased. I treat everyone the same. This is a really similar concept. And I hear that you saying I treat everyone the same has really positive intent. I don't think it has positive outcomes and does not play out the way you want it to be. Equality and equity are not the same. And if we
Sure.
are treating everybody in the same capacity, I treat everyone the same, right? That sounds so inclusive. What you're doing is fundamentally excluding and not considering certain factors that may impact one individual or a group of people. And it leaves us a lot more susceptible to practicing with bias and
Mm,
unconscious or internalized sexism or racism or other discriminatoryism. We have to consciously and intentionally consider the things that are different from
mm.
ourselves in order to give our patients the best treatment.
Yeah, no, this is so good. You there's so many things in what you just said and that boil down to why this matters. You previously we talked about even delayed access to care, right? Like maybe female injured young females are not getting sent out for care, and of course that's going to impact outcomes, right? But then more concerningly, maybe, or equally concerning, is the topic of these preconceived notions that still serve as a barrier once these populations are in our care. Oh my gosh, that is really scary. So it's one thing to not get the care, but then to finally be in a position to get it, but the practitioner with good intention, the outcome is still negative. The impact is still negative. I mean, who wants to be that clinician? Not me. So I want to be enlightened to not treat everyone the same. I mean, that's I feel like, maybe some of us listening are uncomfortable with that because now, I think historically we hear, well, don't focus on the differences, focus on what we have in common. In this case, right, equitable care and equitable clinical decision making and practice, the distinguishing factor is what helps you individualize the care. So we can't ignore that. I mean, that it seems like an oversimplification of a pretty complicated thing, but we have to pay attention to what makes each patient different, specific, obviously, to this topic of gender. So thank you for kind of going there with us and really shedding light on maybe when our intention doesn't match our impact and that sort of ongoing reflection that needs to happen, with clinicians from patient to patient. And sometimes with the same patient, we've got to step back and reassess, what worked last time may not work this time because they have experienced something in the healthcare system that is now challenged their thought of where they're going, their recovery patterns. That's something else that I think we chatted about. Please go ahead.
Yeah. Good intentions only go so far because you can't see or address what you're not looking for.
Mm,
I'm thinking of a paper by Stenberg et al. This was 2021. It's entitled Gender Matters in Physiotherapy. Please go read it. But this paper looked at men and women, cis men and women, and found that this wasn't a study, this was kind of a collection, a review, but that men often viewed their pain as proof of hard labor,
mm,
where women were more likely to feel shame and self
mm.
blame for pain. This was after leaving a primary care appointment, and that men tended to place blame outside themselves. They tended to blame their pain on external factors. Women were a lot more likely to internalize feelings of guilt and see causes within themselves for pain,
Yes.
right? At face value, your patients, cis men and cis women, are coming to you likely in a very different place. They have
Mm,
different healthcare experiences. They might even feel fearful of what you're going to say, or fearful of how you're going to perceive them, or fearful of being judged. They're foundationally coming to you at a different place.
mm.
And I treat everyone the same, or, oh, I just treat the patient in front of me, leads us for so many blind spots. Because again, we cannot see what we're not looking for when we're treating our patients. And I always kind of come back to this thought process, this like gut check, right? Like
Mm,
if I'm sitting here and saying this and your gut reaction is, I'm good, I'm not biased, then truly I'm very specifically and directly talking to you.
mm,
If your internal dialogue is, oh, well, I don't think I'm biased, but how could I assess further? Is something that I'm doing impacting my care? How can I dive deeper into this? then I support that. That is what your internal dialogue should be. But if you're hearing this and you're thinking, that's not me, I'm not biased, I treat my patients great, I'm not letting this seep into my care, then truly I'm directly talking to you. That sense of defensiveness that you're coming up with,
Mm.
that tells me that maybe some bias is seeping into your care, and
That's
that you're
that's
unwilling to assess it.
Yeah, that's that you just said it, right? You took the words from me, which is, sitting with being uncomfortable is good, right? We all sort of know that that's where growth and transformation happens. We tell it to our students, we tell it to our patients in behavior change models is, are you willing to change? That means you're willing to step into a place of discomfort. And so that obviously translate into our own reflections on our practice. I've never met an orthopedic manual physical therapist or fellow who um, doesn't care about improving their practice. And if you're wondering why this matters, why we're talking about this is because we're telling you it will influence your practice. It will drive your outcomes. And that awareness is really exciting to now go back and practice what you're hearing. Even without, maybe if you haven't gone into the research, to the extent that you have, Dr. Shaver, is like, I am now being fed some information that should trigger some reflection. So I love that. Thank you for this conversation. It's so important to understand that how this is going to influence our day-to-day practice. I remember, during residency and fellowship training, just really enjoying the training because I always walked away with tangible tools that I could implement directly. And I think a lot of times that's what we're looking for as clinicians, is not this abstract, study. Those are great, but how do I translate that into clinical practice? And that's what you're giving us. So thank you for that. And kind of along this conversation, you've sprinkled beautifully lots of tools and resources for us, the listener, to help us be aware of our bias, but then to also um, start to move the needle a little bit. This is a continuum and a journey. And I remember thinking too, patient to patient, depending on who the patient is in front of you, it's almost an ongoing within a day of, as a new patient comes, I'm in a different place in my continuum of growth and learning. And that's okay. Patients are supposed to challenge us, to meet them where they are. And we say that a lot, but we can't meet patients where they are if we don't know where they are, which I think is where a lot of what I'm hearing from this conversation as well. Um, Dr. Shaver, I'm always curious about what people are doing, related to or not related to this topic. But before we go there, are there any other things that you want us to be aware of? Any strategies or suggestions, just specific to our topic of OMPT, gender considerations in OMPT practice? Is there anything else you want to kind of just give us today?
Sure. Yeah. I mean, I wish I could give you one succinct clinical pearl, but if there was one thing you were going to do, is to intentionally and consciously spend the rest of your day, your week, thinking about what biases you may or may not have. Like, to truly take a deep dive into your practice and say, oh, did I
Mm,
use language that happened to set that patient up
mm,
to feel like it was her fault? Did I skew my manual therapy practices in a way that was not beneficial to them because of their gender or sex? How do I change this in the future? How do I better validate and listen to my patients that
mm,
have historically been invalidated and felt belittled? Like, I want you to truly take the time to intrinsically process and think about that. And the truth is, almost inevitably, you've probably let a bias seep into your practice in the future or in the
mm,
past, and almost inevitably it'll probably happen again in the future.
mm.
And that's okay, as long as you're willing to reflect on it and acknowledge it and grow. It's when it goes unchecked that it's a problem. and reach out to people that are of different sexes and gender from yourself. Talk to them, ask them what works for them, what they have seen. Like, bring this to your clinic, bring this to your place of work, bring this to your university, and discuss it with people. Make it an active conversation. This can't be a passive change for the field of physical therapy or OMP. And my second recommendation is to read. It doesn't need to be in the depths of your university library. It doesn't need to be peer-reviewed journals. Pick up Roar by Stacy Sim and learn about female physiology. Pick up Unwell Woman by Eleanor Klanghorn and learn about the history of gender discrepancy in healthcare in the United States. Pick up He, She, They by Skylar Baylor and learn about non-binary and transgender individuals, and intentionally read even outside of your field and learn about the collective experience of the people that are most different from you so that you can best help them when they're in front of you.
I love that. Those are outstanding resources. Once again, you're giving us things we can use, and I love that. And I want to take a second to, just hopefully everyone can see the parallel between what you said as far as refining your practice and ongoing reflection. It's sometimes something that I feel like we drill down when we talk about psychomotor skills. And again, we're orthopedic manual physical therapists. We're using our hands. You apply a technique, it didn't go well. So you take a step back and you figure out what went well, what didn't, get the feedback, and then improve. Can we just apply that to what we're talking about here? It's the same framework. It's just a different thing at the center of that practice. And so I love that. For me, that is a parallel that I really connect with. Refining my skills goes beyond my hands-on skills. It's more than that. There's so much more to that. So thank you for those tips. That's awesome. And, as we're kind of closing, I want to talk about maybe some hot topics. I know you talked to me about a course that you're involved in, a female athlete course that touches a little bit on transgender athletes as well. Can you tell us more? Some takeaways, maybe some things for us to consider related to that work?
Totally. Yes. So I teach a course to some sports residents entitled The Female Athlete, but I have basically an entire lecture dedicated to the transgender athlete or treating the transgender individual. And when I talk about this, what I hear so commonly is, that's such a small percentage of the population. That's not really entry-level material. I really want to challenge that here and now, because first, in the United States, there's an estimated 1.3 million transgender humans, right? That is a huge percentage. That's a huge amount of the population. And in my clinic, it's an overwhelming amount of the population, a large amount of the population. So, and truly, in DPT school, I did Sharps debridement on an orange. Okay. If that is entry level information, then learning about the musculoskeletal rib and chest pain that an individual may acquire if they are improperly using their chest binder, that's entry level too, and should be in our residency programs. If my learning how to use ultrasound is entry-level material, then so is learning about shoulder mobility and pain after top surgery, right? Deciding that an entire minority of the population is not entry-level material, or is not enough of them to teach the material in your residency or in your DPT program, is an example of discrimination. I think this material is not difficult to teach, but should be in our curriculum, both in residencies and in DPT programs. And you've probably treated a transgender individual whether you know it or not also.
That's powerful. That's really powerful. We talk about inclusive practice. This is what it is. This is what it looks like. And you're preaching to me, right? Because I do feel like I have a sense of awareness about some of these topics. And yeah, I practice inclusively, but I can tell you that I have work to do. After speaking to you and learning about there are still gaps and how inclusive are we truly in our practice. Now, granted, we are, subspecialists in the world of OMPT, which is why I was really interested in chatting with you about this, is gender topics spans OMPT practice. It goes way beyond that. But if we're going to be specialists within a specialty practice, we have to consider the minority population, right? Like fellows, we do tend to, I can speak maybe for myself and a lot of my colleagues in OMPT practices, you might get that complicated patient. They tend to give you that complicated patient because you're the fellow, you're going to figure it out. Um, and so even within our subsets of patients, we have to consider the minority patient because they may be more likely to come and see us because no one else could figure out what was wrong. So that is, I mean, I think what a great representation and picture of inclusive practice and how to do that. So thank you again. I mean, so many nuggets I think that you have given us and tangibles. I have to now poke you a little further and say, what's next for you in this space or in other spaces? Maybe in your career trajectory, are there studies or initiatives you're excited about? Tell us a little bit more about that, and then we'll wrap it up.
Sure. My future is a little bit vague at the moment. I'm currently finishing the DSC at Bellin, and I would love, my ultimate goal is to kind of transition into academia and then very intentionally dive into the world of researching both gender discrepancy and working and researching the LGBTQIA community.
Enough said. Nothing to add. That's amazing. And there's a lot of work ahead for you, so get ready. As you can see in your own work, you've discovered this. Thank you, Dr. Shaver, so much for joining us and for challenging us to think really critically about gender in OMPT. For those of us listening, those of you listening, we will be sure to get these resources out to you. And until next time, everyone stay curious, stay reflective, keep your hands on and your minds open. Thank you, Dr. Shaver.
Thank you.
Thanks for listening to Hands On, Hands Off, the official podcast of AOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AOMPT on social. Opinions are those of the guests and not official AOMPT policy. See you next time.